So welcome everyone. And I'd quickly like to do a quick land acknowledgement as I'm calling in from Victoria, BC. And I do want to acknowledge that this is the traditional, ancestral and unceded territory of the Songhees, the Esquimalt and Saanich people. So thank you very much. So thank you for joining us again. This is webinar 9. We're going to be talking about psilocybin regulations and research. And we're joined today by both Julia Joyce and Dr. Robin Carhart-Harris. Looks like Robin is just going to be rejoining in a moment here, as I think his internet died. But nonetheless, I will start with an introduction. I'm sure I'll join back in a moment. So Robin Carhart-Harris moved to Imperial College London in 2008 after obtaining a PhD in Psychopharmacology from the University of Bristol. At Imperial College, he founded and led London's Centre for Psychedelic Research, which became the world's first centre focused exclusively on studying how psychedelics can be used in mental health care when it opened in 2019, including designing and carrying out human brain imaging studies with a variety of psychedelic compounds, including clinical trial comparing psilocybin with the SSRI Escitalopram, a major depressive disorder, which was published in the New England Journal of Medicine, and the results of which we'll be discussing with us today. So Robin has published over 115 scientific papers, and in 2021, he was listed in the Time magazine's 100 Next, a list of 100 rising stars shaping the future. In July 2021, Robin moved to University of San Francisco, California, becoming the Ralph Metzner Distinguished Professor in Neurology and Psychiatry, where he will serve as the director of the new Psychedelic Division with the Translational Neuroscience Center in Neuroscape. So Robin will likely be just joining again in a second. Looks like his internet or Zoom just kind of died out there. But I guess that just before we jump into that, I do want to make a couple of comments here, and I feel like this is probably the perfect time for it. I believe is it today, Julia, or tomorrow is the cutoff for the regulations. We've put together essentially a place on our website where any healthcare practitioners, any organizations, patients, or stakeholders in general can add some feedback to the regulations that we've put together with the help of patients and lawyers and Julia, our research director here. So that is essentially a replica or near replica of the Canadian cannabis regulations. Those Canadian cannabis regulations being the obvious starting point, as Canadian cannabis, although perhaps not perfect, is a very good starting place for Canadian regulations for psilocybin, or at least a model similar. In this model, we'd see patients being able to grow their own, being able to seek psilocybin from a medical practitioner, such as a doctor, who's able to support them, and then being able to work with healthcare practitioners. And again, we believe that this is the way forward in Canada, as Section 56 is currently failing patients. We've got a number of patients and healthcare practitioners who have waited over 170 days. So we'll get more into that in the in this webinar. But Robin, now that you're back, awesome. I just did your introduction. So without further ado, I will turn it over to you, as I believe you've got a bit of a presentation just to start off with what you've been working on.
Yes, yeah, happy to present. I think I need to have the ability to share my screen, which is up now, which is great. So nice to be with you, everyone. Happy 9/20. So this is actually the first time I'm speaking to anyone in a presentation format since moving to the US. That was less than a week ago. I think this is day 5 for me in California. So I'm adjusting. Forgive me if I'm not quite, 100% on form, but yeah, happy to be with you and very happy to be in California, starting a new life here. So hopefully you can see my slides here. What I said I'd do is just focus on the depression trial. You probably heard that while my internet cut out. I'm on hotspot now, so hopefully it'll work. is focus on our recent double-blind randomized control trial comparing 2 dosing sessions with psilocybin 25 milligrams with escitalopram, 6 weeks of escitalopram, daily escitalopram. It's a relatively well-performing selective serotonin reuptake inhibitor antidepressant. So a kind of highly selective serotonin reuptake inhibitor and a kind of conventional antidepressant, one of the better performing by tolerability and efficacy. People get 6 weeks of that in the blue corner if they're in the escitalopram condition. And they also get dosing sessions with all the psychological trappings, if you want, that we have for the high dose psilocybin condition. So they actually receive psilocybin, albeit just 1 milligram, which we presume and have some evidence to believe is inactive as a dose. It has no discernible effects on brain activity, at least when we measure that with EEG, looking at brain waves. You see nothing versus placebo with 1 milligram of psilocybin. So very low dose, but what it enables us to do is standardize expectation to some extent, at least in the first dosing session, because we can say to everyone at screening and into the study that everyone will receive psilocybin. It's just that the dosage will differ. So that kind of psychological side of things we believe to be so important. And in a sense, you could say it's a tough test for psilocybin because people are getting 6 weeks of an evidence-based antidepressant intervention. And, by regulatory standards, there's only one here. It's the escitalopram. And so we're going against something that's licensed and used by, I presume, millions of people. And they also get psychotherapy or psychological support that you get with psilocybin therapy. They have the dosing sessions with all the music and set and setting. So I think it's fair to say pretty tough test. So that's the design, and it's randomized. Effectively, it's a coin flip as to what condition people go in. The population is the people with major depressive disorder, which in layman's terms is depression, sort of bog standard depression. Severity has to be at least moderate into severe. And so we're not talking about mild depression, but at least moderate depression. What I've done is I've just jumped straight in. Perhaps I should have shown you the demographics, but generally speaking, a sort of middle-aged population, quite well educated. Gender balance was 60-40 male. Could have been better in terms of a more equal representation and more reflective of the depressive population, which is actually slightly higher in females. So, and then ethnicity wasn't quite where we'd want it to be. It was largely white ethnicity. So room for improvement there. But that's, in terms of general terms, the demographics of the population we're looking at. So I'm showing you tolerability to begin with. We'll go on to efficacy, or how well each treatment worked. And this slide, these are forest plots. This is a forest plot. When these bars, which are confidence intervals, do not cross this dashed center line, you can feel greater than 95% confident that there's a difference between the conditions. If the bars are over on this left side and we're looking at different adverse events effectively, we can feel greater than 95% confident that, for example, anxiety is, there's less of a risk of that in the psilocybin arm versus the escitalopram arm. If any bars were over on this side, again, remember these bars have to cross the midline, then we would think that there's greater risk with the psilocybin. And what you'll notice is there's two that are green because they cross the center line. And so here we can feel greater than 95% confidence that with 95% confidence that there'll be less anxiety and dry mouth reported in the psilocybin condition. Otherwise, it's, broadly speaking, it's a kind of even spread. Headaches were a little more prevalent in the psilocybin condition because they're quite prevalent. Transient headaches of mild severity are often reported one day, sometimes 2 days after a high dose psilocybin session. But in terms of severity, patients were rating those as mild, and that's what bumped this bar up more generally, and also all adverse events. But some of these more peripheral adverse events, they're sort of trending towards being less prevalent in the psilocybin arm. These are reported throughout the 6-week core trial period. So they're not just linked to, say, dosing with psilocybin. They're at any time when we interact with the patient, did any of these things occur? So that's the picture that we get here. We also looked at tolerability in some other ways. What I would say to you, if you're interested in this trial, and if you're interested in psilocybin or psychedelic therapy, I think it's reasonable to say you should be interested in this trial and read the paper very carefully. And my point to emphasize is read the supplementary appendix of this paper, because a lot of the data can be found there. Because of editorial control and so on, we don't have complete freedom in what we can report in the main paper. Things get reduced down. But data is data, and you can find it in the supplementary appendix. And I do encourage you to read the paper in detail and look in that supplementary appendix. You'll find it online. It should be open access. And if it's not, write to me and I'll send you the relevant documents. So here we created a scale that we call the post-treatment changes scale, in a sense to try and overcome any biases that we might have. Say in favor of psilocybin, which is what you might imagine could be there. And so we looked at domains of tolerability that have been linked with psychedelics, whether fairly, whether justified or not. And we asked people about them, and we call it post-treatment changes scale because we ask whether the prevalence of any of these domains, like the ability to cry, increased or decreased in relation to the treatment that they received. And we asked this at the what we call the trial endpoint, which is after 6 weeks. So for example, if you went into the Escitalopram arm, it's right at the end on that 6-week endpoint. If you're in the psilocybin arm, it would be 3 weeks after the second of 2 dosing sessions with 25 milligrams psilocybin. So if you see a positive number, there's an increase in the prevalence of this phenomenon. So people did feel an increased ability to cry in the psilocybin arm, increased ability to feel compassion, to feel intense emotion, to have creative feelings, to have feelings of pleasure. A key symptom domain of depression is the inability to experience normal pleasure, or anhedonia is the term. And so we're seeing improvements there with psilocybin and also ability to concentrate. Now you look at Escitalopram, modest changes here, and actually ability to cry decreased, if anything. And then here we do the contrast. And this is like a forest plot. These are 95% confidence intervals, such that if they cross a 0 midline, as happens here, for example, we can feel greater than 95% confidence that there's a difference between these conditions. So in short, if we're looking at this one, they're all positive numbers, nothing goes into the minus domain. And in fact, it's true of all of these domains here, all of these positive items. If you feel the ability to cry is a positive thing, it's arguable, I would say it is a positive thing, then it's a significant increase in prevalence in the psilocybin arm relative to the Escitalopram arm, all of these domains here. Let's go to the negative domain, and here you'll notice some things that have been linked with psychedelics, again, whether fairly or not. And so we thought, well, let's, stick our neck out. So let's be brave and see whether they increase or maybe decrease after psilocybin therapy versus escitalopram therapy. So a problematic restlessness, kinesthesia, I forget the term, is kind of restlessness sometimes associated with SSRIs and other psychiatric medications. So we looked at that. It was a decrease with psilocybin, significantly greater decrease with psilocybin. Feeling manic, you never know. So we looked at it. It was a decrease at the end of the trial on average. Feeling paranoid, of course, that specter that hangs over psychedelics. Do they induce prolonged psychotic symptoms? It was a decrease with psilocybin, no change. And actually it was a significantly greater, or at least greater than 95% confident decrease with psilocybin relative to escitalopram. Headaches, more, well, actually, despite the spontaneous reports, if you ask people directly, they're saying they were having more headaches in the escitalopram than the psilocybin. So it's somewhat confusing, but still, that's there. No troubling perceptual changes. Hallucinogen persisting perceptual disorder, another specter that hangs over psychedelics. Just checking the timer. And of course, it's healthy, it's right, it's proper to ask about these things rather than kind of brush them under the carpet. So we did, and no cases. And we did it in a very thorough way. We provided participants, patients with the DSM, the diagnostic criteria for HPPD. And so they had it described, as it's formally described, and yet no cases of that in the psilocybin condition, not in the escitalopram either. And a few of these others you could look at. In the interest of time, again, I just say, dive into that supplementary appendix. If we're looking at efficacy, so what you do in a trial, it's good practice, is you pre-register the main measure that you're going to compare your two treatments on. We chose the quids, sod's law, depends where your bias is, but it was the only efficacy outcome that didn't separate in favor of psilocybin with greater than 95% confidence. All of these did. 3 of them are very validated depression rating scales, 1 done by patient, 2 by clinicians. Whoops. And then here we're just looking at sort of ancillary outcome domains, avoidance, where there's an increase in acceptance rather than avoidance, if you want, the ability to sit with emotion or psychological flexibility, increasing quite markedly with psilocybin versus escitalopram, anhedonia improving, social work and social functioning flourishing, anxiety decreasing more in the psilocybin condition, well-being increasing more. We flip the direction to get it all on the same chart, and suicidality decreasing more with psilocybin and escitalopram. So this isn't a picture that's so obvious when you read the abstract of the trial, but again, data is data. I do implore you to read the paper and look at the data and look at the supplementary appendix to get a clearer picture. Here are the more sort of temporally precise trajectories of change here. Well-being, psilocybin leaping up. This was a significant difference here. And this is the quids that didn't separate at 6 weeks, but there's suggestions that it separates at other time points. Indeed, if you just analyze the first week, there's a significantly greater drop in depression scores with psilocybin versus escitalopram. Now, this is important. I'll check time and just do it because we started a little bit late, but I'll still save time to have a chat with Spencer and open things up to questions. Discontinuation. So if you're coming into a depression trial, you may, and with psychedelic therapy, you may be coming in just medication free. Perhaps you don't like psychiatric medication, you tried psychotherapy, you're thoroughly depressed, you get into the trial, or you're on an SSRI, and because there's some evidence to suggest that psychedelics attenuate, or rather being on an SSRI attenuates the effects of a psychedelic, you discontinue, you come off. Now, in that population, which was actually the minority, 2/3 weren't on any medication coming in, but 1/3 were. In that 1/3, there seems to be a problematic effect where there's no difference between the two conditions. If you're coming off a med and then going into the trial, one of the arms, you go back on a med that you've just come off, or you get psilocybin. And in that subsample, there was no difference between the conditions. But look at it another way. In the 2/3 who did not discontinue any meds coming in, all of the outcome measures, without exception, significantly favored psilocybin for efficacy. What's the take-home message? Discontinuing conventional antidepressant medications seems to do something differently to each condition. If you go onto an SSRI or back onto an SSRI, you do well. If you go onto psilocybin, you do less well than you would have if you hadn't come off any meds at all, because you just weren't on any meds. It's not that you stayed on the meds, you just weren't on them, and you came in with a fresh brain and body, if you want. If you're one of those people, then you do very well. So discontinuing meds, being on meds and then discontinuing seems to be an issue. You can see it here when we look at it in a more temporally precise way. No difference between the conditions. This unfortunate discrepant baseline here with the psilocybin condition being lower in those who did discontinue some meds to come in. Those who didn't discontinue, it was statistically significant even on this problematic rating scale, the QIDS. So again, the take-home message, discontinuing SSRI medication seems to be an issue, particularly in a 2-arm trial where one of the conditions is an SSRI, maybe because it feels good in a sense to go back on a med that you've come off or one closely related to it, or because something's happened with the med that has attenuated the effects of the psilocybin. Anyway, it seems to matter. What are the implications of that? Well, pragmatically, you might just lengthen the washout period of a medication if you're on it when you come into the trial. Now, I've got to emphasize that that has to be managed carefully because it's not a trivial thing to do. There's often discontinuation effects, and clinicians differ, as academics do, on the seriousness of these discontinuation effects. But in these data, it seems to be a thing. And so, you know, at least in this trial, it seems like there's something there. So a longer washout period is all I could suggest pragmatically if psilocybin therapy is to be the treatment. So I'll end it there, and thank you for your attention. Do read the paper, read the response to some letters that came in as well, and yes, scrutinize and see what you think. Thank you for listening.
Thank you so much, Robin. And I just want to, say first of all that the, TheraPsil and I think the state of Canada right now and having granted Section 56 exemptions, this exists because of researchers such as yourself that, provide both Canadian patients, the public, and Health Canada with information that turns, psilocybin from just a mushroom, right, to actually a reasonable medical situation or reasonable medical choice for patients who have tried everything else. And that's quite something, because it's not like there's tons of research, but there's some, and it's growing. And it looks like from listening to you speak and listening to the way you design this research, even when you're trying to flush out the demons of psilocybin, if there are many, that even those don't seem to be as bad as perhaps some of the propaganda we may have been told. But I do say it's amazing. It's amazing research, and it does strengthen a lot of what we're hearing from patients and healthcare practitioners who today in Canada are using psilocybin. So I just want to hear in your own words too, because I mean you speak extremely well, and then this research is very well done. But in your own words, I mean, what's going on here? Why is psilocybin a valuable therapeutic tool? What do you think's happening?
Yeah, I think it's working differently to conventional drug treatments for depression. So those conventional drug treatments, I just sort of say this in very general sort of lay terms, they seem to take the edge off things. David Nutt put it nicely in a documentary. It's available in the UK. I'm not sure if it's crossed the ocean yet, the pond, but he said they incubate against stress. So they kind of smooth you out. They help you get by. Some people like that. Some people say they feel kind of depleted because of that approach. They don't experience the highs and lows of normal life in all its richness if they're on SSRI or related antidepressant medication. And so they, the sort of harsher term is to say they feel like a zombie when they're on their SSRI. Emotional blunting is another term. Psychedelic therapy seems to, in a way, do the opposite. There's a kind of rawness to people, an emotional rawness, and in a sense you could see that as a vulnerability, but also it's like it is a kind of recalibration. People are able to experience the richness of life in a way, and with the right psychological support and therapeutic container and community, which seems to be so important. They welcome it so much, and they say that this is just a world apart from other treatments they've had in the past. Even psychotherapy, which is a lot of, could take a long time to really see benefits, and often expensive and systemically expensive. And so if you can catalyze some of the good stuff of psychotherapy, with a psychedelic, that's really, I suppose, where the kind of magic is happening. And so it's a different quality of therapeutic action. And did we have a bias sample? Maybe people came in really hoping for the psychedelic therapy. We can look at that because we measured it. We're doing that now. But it certainly shone through that when they responded to the psilocybin, they said that this I feel great. And they just don't say that with an SSRI. So yeah.
Well, and that's interesting too, because I've heard in the past that SSRIs are becoming less effective, sometimes just because of perhaps placebo effect. And people, if they feel like they're being helped by something, then it's helping. And so there must be a certain amount of pragmatism towards the substance that people think is going to help them. That may even go beyond, whether it's actually has a method of action, right?
Yeah, sure. I mean, the placebo is a thing with psychedelic therapy as well. So positive expectation. And I suppose in this trial, you're kind of balancing for that. Blind is broken through, maybe you notice the SSRI, you notice maybe some of the side effects or the emotional blunting. With the psychedelic, you notice the profound altered state of consciousness. So, so there is that rupturing of the blind, but the blind is a kind of game that we play. It's the gold standard. It's the way that things are done. But is it fool's gold? I don't know. It's even in SSRI trials, SSRIs versus placebo, is the blind really upheld? How many FDA grade trials that have been done that have led to the licensing of medications and now multi-billion, trillion-dollar, I don't know, industry, has the blinding been effective? And how many researchers out there measured the effectiveness of that blind? So positive expectation is part of medical intervention. And I just do wonder whether there are other ways of doing these trials. I don't think we should entirely do away with double-blind RCTs, but having done one, I can see the flaws in them and the flaws in our assumptions about their rigor. So, yeah.
That is interesting. One thing that I like to remind folks about at TheraPsil is what we're doing is not always, following necessary the clinical research and the model we have for research, because research is important, especially when you're working with new substances, going through your phase 1, 2, 3, 4 clinical trials. It's important. One of the things we've been noticing though in Canada is, the outright prohibition of a substance doesn't always work. And, you can imagine that even with cannabis being, prohibited back in the 90s and before that, people across Canada were smoking cannabis. And today, Many more people are now supported by their doctor and physician as they're doing that. And the same is going for psilocybin too. There are not only a ton of Canadians seeking treatment underground and also buying psilocybin. Actually, today in Vancouver, there are street corners with shops that are selling psilocybin, and it's not being stopped by the government. And the government knows that there are doctors and patients using and asking for permission to use. So we've thought that an obvious response to this is to create some form of regulations, because it almost seems like we're in this weird world where there are tons of people using psilocybin or seeking access to psilocybin, and the research is somewhat limited, both perhaps because of the way research is, but I think more importantly that it must be difficult to have or to conduct research with a prohibited substance. And so I'm wondering if you could talk about that a bit, what it's like to do research with a prohibited substance, and if you think that regulations, and if there's any sense in making research and quite frankly having patients able to be supported by their healthcare practitioners, if you think there's any sense in that.
Yeah, I mean, I've got to say that research is essentially important, and we are where we are right now because of research more than anything else. And it's easy to get ahead of research. Something like the microdosing phenomenon could be something related to that, where now there are drama series that are quite popular that are sort of suggesting it works in a ton of magazine articles, and you look at the scientific evidence and it's pretty thin on microdosing. So I do think the research is essentially important. So what I would say about the research is that, if people are, there are different sort of types of research. And so, real world evidence, people who are just using because they're going to those stores in Vancouver where they can get mushrooms, or they're ordering, I don't know, grow kits online, or basically they're taking matters into their own hands, then I can't see an argument against collecting data when that's being done. It's why we set up psychedelicsurvey.com 5 years ago, or whenever it was. Now Mydelica is a system that we want to do similar things, collecting real world evidence. I can't really see a good argument not to collect data. And it's a different type of research. It's not a controlled, double-blind, randomized control trial. So you don't control as much, but in a sense, there are merits in the naturalistic validity of the data that you get when you collect real world evidence. So if doctors are getting on board and prescribing and so on, I know that, you guys are working to open that up, and essentially, they can't easily do that now in many jurisdictions at all. But if they are doing that, then one would hope that they would ally with research and collect data. And, in the real world setting, real world evidence, we can look at some of these specters as well, as I called them, the things that really worry people, as we've seen historically with cannabis. What is the risk of, precipitating a psychotic disorder through the use of any of these substances? And we can only really know that if we collect data. And actually, I think if we're collecting real world data, we'll probably get a clearer picture about the actual risks of such things.
Absolutely. I mean, you almost just have far greater samples, right? Sample sizes and much more room for innovation too. I mean, I really appreciate your response, because it's spot on. Research is absolutely essential, but also a pragmatic approach to, dealing with people that are using psilocybin today, and making sure that as that's happening, we have the best outcomes for patients and the healthcare practitioners who inevitably will be working with them. That is important.
Yeah.
So yeah, I mean, I feel like this is a good opportunity, Julia, to pass it over to you. I mean, TheraPsil is working right now on collecting some research. Do you want to quickly comment on the research that we're working with? In fact, with, I believe, Imperial College is helping out a bit.
Yeah, for sure. So we're in the process at TheraPsil of also trying to collect some observational research that will capture both quantitative and qualitative data for anyone who's being granted a Section 56 exemption for psilocybin use in Canada. So with the quantitative arm, we're actually working with Imperial College and we're using the Psychedelic Survey platform. And then we're also working with Northern Ontario and McGill in Canada to also design these qualitative surveys that will ask sort of interview style questions to both patients and their caregivers. And it's quite interesting, like speaking to my colleagues here in Canada who are working to kind of create this research, they had a neat way of describing this kind of research as almost a post-phase 4 study, as this is research that is really looking at psilocybin therapy and its effect in real life and within the community setting in Canada. So I think that's really special and unique, and hopefully this data will help aid some sort of policy changes and inform larger trials that may need to happen with psilocybin as well. Kind of like a niche thing that we have kind of going on here. So it'd be really great to capture this data. And a sort of question to throw back to you, Robin, as well, just kind of looking at our audience, not only in Canada, but sort of internationally as well. Many people still do have the perception, and I'm sure, you know, everyone's sort of met it, that they have the belief still that psilocybin is addictive and dangerous. What would you sort of say in response to that? Because I know, you know, from Imperial and also the work that David Nutt's done, they've kind of tried to combat these perceptions as well. Understanding that psilocybin does need to come with a warning, people should be wary, but with the belief, people thinking it's addictive and dangerous, what would you sort of say to that?
Well, I just go to the data and there isn't any compelling evidence whatsoever of any addiction potential with psilocybin. Animals don't self-administer psilocybin and related psychedelics. If anything, they seem to be sort of fundamentally aversive rather than hedonic. Like they don't directly and reliably induce pleasure. The experience is more complex, it's psychologically rich, and when psychedelic therapy is done, it's that richness that is part of the therapeutic vehicle, but it's certainly not, you know, a kind of high, a kind of, you know, hedonic high. And because of that, people often just don't necessarily want to go back there in a hurry. They've had an incredible, profound experience that's changed their outlook on everything, life, death, themselves, their relations, and so on. But they don't necessarily want to, you know, do that again in a hurry. It was pretty weird and at times, you know, kind of scary. Mm-hmm. So that's the picture. So dangerous, there are dangers, there are risks, which is why we advocate for controlled administration with a sober guide, you know, if I'm speaking in more of the sort of people taking matters into their own hands, harm reduction kind of messaging. In the research, we have 2 therapists, at least one is a mental health professional, a psychiatrist or a psychotherapist, and 2 is good for holding space. One can leave the room and another is always there. So there are these safety standards that we uphold. So yes, there are risks, like you don't want to say, oh yeah, it's a free-for-all, you could take your psychedelic and be out in an urban environment. That's not the messaging at all. It's controlling the risk through good practice, essentially. And there's a way of taking psychedelics, which is abuse, which is kind of like reckless, carefree use. That's the drug abuse in a sense. And then there's a more mindful way of using the substances, which very much mitigate the risks and increases potential benefits.
Mm-hmm. So where would you sort of say the future of psilocybin research is heading? Like, what are the kind of things that I'm sure you have with Neuroscape, some exciting things planned over there? Where do you sort of see the field, the next step happening with research?
Well, there's a lot of people looking at a broader range of indications now. So, you know, broader cross-section of psychiatric illness, which is good. And it's interesting to see people, for example, Josh Woolley at UCSF going into bipolar, looking at bipolar is very daring and interesting, and, you know, more substance addiction domains as well. We're doing anorexia work. I say I still consider myself part Imperial. We're doing that anorexia trial, psilocybin therapy there, Hopkins doing similarly. So that's healthy. And then with Neuroscape at UCSF, the psychedelics division that I'm I've come in to head up. Mechanistic translational research is a lot of our focus. So that means, for example, drilling down into substates that occur within a psychedelic state. I think it's a major knowledge gap there about the nature of these substates, say psychological struggle states versus release states, letting go, what they are in the body and the brain and the mind and in experience, and how to pick them up, how to sense them. And then if you sense them and you know that they're important, then do you intervene to try and promote certain states or abort, in a sense, other states like struggle states? It's a complicated one because maybe there's something in the struggle that is formative, that's useful, but you can again go to the data there, and there's some evidence to suggest that unending struggle isn't a good thing. So if you can engineer the context, the set and setting in a way to promote release substates, then that could be very beneficial. And so in a sense, improving psychedelic therapy in an evidence-based way. And some of this, you might think, oh, it sounds very techie and some distance away from, I don't know, indigenous use of psychedelic plant medicines, but don't be so sure about that. Shamans use or curanderas, they'll use scent and flower water, blowing that into the air, and other things that aren't used in the research. So maybe some of these inventive, creative ways of manipulating context are actually, in a ironic sort of way, closer to some of the many generations of trial and error that's been done with indigenous use of psychedelic plant medicine. So yeah, there's a lot to do, and that's just one sort of domain that I've talked about there.
No, awesome. It'll be exciting to see, as we've looked at different styles of music and how hearing is one sense, how we can actually look at all the senses to see how they may change. You've opened up a whole door of exploration there, which I'm sure will be some interesting findings.
Yeah, so it's going to be fun. Yeah.
It's also it's awesome to hear that there's quite a bit of research expanding into new indications. It's something that at TheraPsil we've also done is, we started off supporting patients who are at the end of their life with a terminal diagnosis, and have recently also expanded. And that's coming from feedback from the patients and the physicians to the doctors, essentially saying that, what's the difference between this patient and that patient, right? Their symptoms are similarly being treated. Their symptoms of anxiety, depression, hopelessness. Why do we have to wait until they're dying? So I really hope that research, advances quickly, about as quickly as people are applying and seeking access, because it's going to be vital, and there seems to be many different use cases. Now, I realize we've got about 10 minutes left here, and I want to make sure we get through some of the audience questions here. So I'm just going to run through some quick ones here. It looks like there's about 10 of them. So let's see how many we can get through in about 10 minutes, and while being informative, but also minding that there are a few. And for anyone who's typed in a question, I'll do my best not to repeat any of the questions. And if it does not get answered, I'll make sure that we do record them, and we'll send those responses. We could probably even get your name and try and get a response to you. So to start off, with the depression studies you were involved with, where patients with treatment-resistant depression relapsed months after a quite dramatic response to psilocybin, it was not possible to further do any more psilocybin trips. However, do you think that in practice, this would be the correct treatment? And are you planning on studying this? So I guess treating a patient again, and I'll quickly just add in a little point there, is for some of the patients that we've worked with in Canada, legal section 56s, some of them did find that the first one was not effective and tried others, and found that it was sometimes a bit more effective. What are your thoughts based on your research? Do you have any interest in looking at that?
Yeah, very much have an interest. And, I guess COVID vaccinations are a useful analogy, in a sense, where a third vaccination, now there's some evidence that it really increases immunity. And so, the term that's used is booster dose. And most of the research has had either 1 or 2 dosing sessions, not because we believe that's optimal, just because that's sort of pragmatic in the context of a research study. And so, going forwards, I think more research, pragmatic research that is somewhat less constrained and more responsive to what, in a sense, clinician, still collecting data, doing research, but what clinician is seeing will have more naturalistic validity, and tell us more about what things will look like post rollout, assuming that it is going to happen, that these treatments will get licensed. Then yes, I think it's a compelling hypothesis, put it that way. And often I think you can look, in a sense, to the underground for clues, and underground therapists, they'll use dosing sessions in this more discerning way. They won't necessarily restrict to just 1 or 2. They'd be more open. They'd be open to switching as well. So psilocybin therapy is not having a breakthrough, then maybe MDMA therapy. So that kind of creativity that you'll sort of, in a sense, see in the underground is useful, I think, for hypothesis generation and then, testing going forwards.
Awesome. And there seem to be a couple questions here about SSRIs as well. So the Escitalopram, patients tapered on and off in addition to the 6 weeks. And I guess Kaylee wants to know, doesn't Escitalopram typically take 4 to 8 weeks to show effects and then require weeks of careful tapering on and off? And again, all that little pretext is this is probably one of the biggest issues that we've had at TheraPsil too, is, as you can imagine, almost every patient that we work with is on some form of SSRI, and getting on and off those SSRIs and just drug dispositions and interventions has been very, very difficult. So could you tell us a bit about what you experienced in the research?
Yeah, very consistent. It is difficult, whether it's our first trial in TRD, treatment-resistant depression, or the more recent trial in major depressive disorder that was broader depression, not just treatment-resistant. You're still seeing a lot of people, particularly with TRD, but also in major depressive disorder, a third of people being on some kind of medication, and coming off isn't easy. And we had this window of being off the med for at least 2 weeks before the first dosing session with psilocybin. And that the data suggests that wasn't long enough, whether it was a brain adaptive effect, like down regulation of the target serotonin receptors that classic psychedelics work on, the serotonin 2A receptor, maybe through years or months or whatever of SSRI use, those receptors are kind of hidden away, because in a sort of adaptive way, and so this is why there's, in a sense, controversy around discontinuation, because a lot of patients are saying it's hard coming off, and in a sense it's like an addiction. I'm having withdrawal effects coming off this med, and no one really warned me that this was a possibility. And now am I consigned to being, I've got to go back on this med to, it's a tricky situation. So it's an issue, I think, for psychedelic therapy and the rollout. You're seeing it, we've seen it, other teams see it. People wish and hope that it's not a problem, that maybe you can even dose on top of your SSRI. I'll wait and see in terms of the evidence. I do have a view, and I think it will attenuate, and you won't get the outcomes that we see when we do washout. But let's let the evidence speak for itself. But that would be my hypothesis. So yeah, it is an issue, but maybe it's part of a bigger major pivot that we're just just starting to begin, in a sense, maybe away from pure drug treatments in psychiatry. It's a big thing to say, but maybe this is a direction that we could could go in, and maybe we'll look back and think that what a crude way to treat mental illness as we look back at things like psychosurgery, you know, or even in time ECT. I mean, there's efficacy there, but do you really want to be inducing a seizure? And people don't like that. You know, so I think it's possible that we're on that pivot now away from this, in a sense, quite crude approach of just, you know, throwing drugs at mental illness.
For sure, and I can report that that has been a huge point of stress for many of the physicians and, again, patients who, you know, are told you have an option, SSRIs or, you know, talk therapy. And for some of them, they go, well, what about psilocybin? And unfortunately, you know, as part of the Section 56 process, some patients and doctors are being asked to try every treatment. And I think it's reasonable to explain to that for some people, SSRIs is not a reasonable medical choice. Nonetheless, some of them are asking, you know, why do I have to go on something that's potentially addictive? So I just personally, as a comment, I find it interesting that, you know, there are patients that had issues discontinuing medications. And is it reasonable to assume that if psilocybin is able to, you know, perform well in all of the clinical trials necessary in order to become a drug, do you think it would be reasonable to maybe try psilocybin first before trying an SSRI?
Well, that's why we did our major depressive disorder study rather than more research in TRD. I mean, a major learning for me from the TRD trial was that this might not be the best population for psilocybin therapy. There's a lot of comorbidity, as we call it, you know, a lot of complexity, personality complexity, and a lot of medication. And so why should there be a rule that says you have to try SSRIs first and fail them, and at least 2 different types of antidepressants before you're even allowed the option of psilocybin therapy? That just didn't sit with me. It wasn't consistent with the observations from that first trial. And that's why we went into major depressive disorder. And you could say, in a sense, that similar arguments could be made to broaden further, you know, and I know that's a daring thing to say, but, you know, maybe there are benefits in lower grade depression, lower well-being and so on, with actually concrete improvements to be seen in things like general functioning, healthier lifestyle, you know, social outcomes, social functioning, social connectedness, loneliness. And these are major kind of sort of subtle issues, but important ones. And I think there are arguments that could be made that are evidence-based, again, for real benefits for being brave and going into, you know, broader populations. And I actually think eventually it will happen as a matter of kind of sort of logic, in a sense, but you know, might not happen overnight.
No, it'll definitely take a bit of time, but we're definitely seeing that it is out of logic, you know, that people think, oh, well, why not use it for this? Why not use it for that? And I'm sure you're already seeing a ton of anecdotal evidence coming from, you know, reports of people experimenting.
Yeah, and better than anecdotal, you know, it's quantitative data in big populations doing things like the psychedelicsurvey.com approach. And sure, you know, there could be a lot of biased samples here and, you know, different biases in the data. But I think if we're collecting, you know, bigger and bigger samples in the real world data approach and pragmatic trials, we'll get a clearer sense of the risks. And it's not to say, you know, when speaking about all of this, it's easy for people to hear it and get carried away, as perhaps, you know, maybe I do as well. But it's not to say that there aren't risks. There are always outliers, if you want, and anomalies. But if we're, you know, data-led and consistent with principles of harm reduction and so on, we can mitigate those risks. It's better to kind of recognize and address head on rather than try and brush them under the carpet. So yeah, there we have it. Yeah.
Awesome. And I've got just one last question for you here. Unfortunately, we won't be able to get to the other questions, but I'm wondering, I'll make sure we get these recorded, just so we can throw them on perhaps a Q&A or make sure they're covered in our content. But this is the last question from Mohammed. So I see the current wave in psychedelic research as a paradigm shift in the current treatment systems of psychiatry, as compounds like psilocybin require an even greater degree of psychotherapy and guidance than the current medications being prescribed for, say, depression. Once psilocybin is approved for clinical use, do you think it would be licensed as a prescribable medication, or do you think it would only be approved if paired with psychotherapy? So I guess it's essentially a question about, how do you think efficacy will change in safety with or without psychotherapy?
Yeah, well, I do have a view, and I hope that we never go down a track of drug alone with psychedelics. I think it would be a big error. It would be bypassing, in a way, what's essentially, an advance with psychedelic therapy, which is that it's holistic. It's a combination of drug and therapy, catalyzing therapy, not being too brain specific, but being more body, brain, mind experience. So no, I do think the therapy is essential, and I think if people try and strip it away, it's going to. I don't think it's going to help the space and its healthy development. So I think people should think very carefully whether it's microdosing or these non-psychedelic psychedelics. I don't buy it. This has got to be thought through, because the secret sauce, if you want, it's not that secret, but it is in this synergy that happens with essentially a catalyzer of very deep therapeutic processes with the psychedelic.
Well, wonderful. And I just want to say thank you so much. I mean, research has been a part of our core pillars at TheraPsil. We've got 4. First is compassion access. The second is public education. Third is training, and then research. So really, thank you so much. You've been incredible, and your research has been incredible, and it's an absolute pleasure to speak with you and hear it straight from you. So I just want to give you a quick opportunity, if you have any closing thoughts or anything else you'd like to say that we didn't cover.
No, just to express my gratitude for having me on and organizing this, and for the good work that you're doing, and to say to people, be safe, be wise, and it's almost like a catch phrase. It's a bit cheesy, but be well.
I love it. Awesome. Well, thank you so much, Robin. Thank you, Julia, so much as well. And I look forward to seeing how your research goes, and to reading it, and to using it and sharing it with the Canadian public. So thank you for everything you do, Robin. And I really do wish you the best down in San Francisco with Neuroscape. So I hope you're acclimatizing well to California in the US. And I look forward to hearing from you.
Sunshine. Yeah, it's all good. Yeah. Thank you. It's been a pleasure.
You're welcome. All right. Take care, and thank you everyone who attended as well. Have a lovely evening.